Hello, I'm Professor AFGCicero. I'm professor of human nutrition by the University of Bologna, and today I will shortly speak you about sarcopenia, a relevant risk factor for cardiovascular and total mortality in general population and in particular in elderly people. What is the definition of sarcopenia? We have seen different definition during the last years, slightly different in Europe and in the United States, but overall the definition of sarcopenia is relatively easy. We can suppose to have in a patient diagnosis of sarcopenia when we find that he is experiencing a decrease in muscle strength. The diagnosis is somewhat confirmed by additional documentation of reduction in the quantity and quality of muscle distribution in the body, and there is a third criteria that is more a severity criteria than a diagnostic criteria that is related to the physical performance of the subject. That's like to say, when the decrease in strength and in quantity or quality of muscle mass is so relevant to significantly impact in the everyday life activities of the patient, then the sarcopenia is considered to be severe. And we have to say that usually in the normal, in standard condition, with the increasing of age in general population, there is a semi-physiological or paraphysiological decrease in muscle strength. This is more evident in men because usually the strength is higher in younger age, and it fall down very quickly and deeply after the age of 60, while in women the decrease is less impressive because the starting level is less high, but for the same reason, the minimal level of strength that can be achieved is very, very low. It could be really debilitating for the everyday life activities. From here, we really understand that the best way to prevent pathological sarcopenia is to accumulate, to increase, to maximize the muscle mass in the young adult age, because then the decrease and the final strength will be less impacting on the everyday life. The reasons for the physiological, the semi-physiological sarcopenia are the most different and are mainly related to the fact that people usually reduce their physical activity with the age. They usually reduce the diet variability and the intake of protein, and often they develop inflammatory diseases of various entities that could negatively impact on this condition. We have a very, very simple questionnaire that can help us to detect, to screen sarcopenia, and it's the SARC-F questionnaire that investigates about strength, assistance in walking, rise from a chair, climb stairs, falls, with a very, very easy score, accounting from 0 to 2 or 0 to 0 to 2 for all the questions related to these items. As you can see, this is something that can be done by everyone in this practice. Of course, after we have detected the subject at risk for sarcopenia, we have to confirm this diagnosis. As we said before, in order to increase the awareness and also the rigor in the diagnosis, we have to measure the strength of the subject by usually two very easy tests that are the grip strength test and the chair stand test, where we have to measure by an instrument, in the first case, the strength that the subject has in his hands, and the chair stand test, and where we measure the ability of the subject to get up and to sit in a standard chair. Of course, both tests are limited in subjects affected by severe osteoarthritis or osteoarthritis and inflammatory joint disease, but excluding these cases, it is usually very reliable. Then, when we have assessed this, we can improve our diagnosis by quantifying and qualifying the muscle mass distribution with different technologies. The most used now are the DEXA and the BAIA, while the tomography and the magnetic resonance are less used because they are more invasive and more expensive. One time we have defined the sarcopenia, we have to evaluate the physical performance of the subject one more time with different physical tests that are validated to measure the limitation that the subjects clinical in everyday activities as a consequence of the severity of the sarcopenia. The main problem with the sarcopenia is not only the weakness. The main problem with sarcopenia is the final consequence in terms not only of impairment in quality of life of the subject and in the degree of autonomy in the everyday activities, but also because the cause or the cause-acting factors involved in sarcopenia development are also involved in the most part of chronic degenerative diseases. It is very relevant to remember that a sarcopenic subject is usually a subject that is strongly inflamed, and not only inflamed only in the sense of the typical way of meaning that we have about inflammation. For instance, in the case of the acute inflammation, but in a kind of small, in the case of chronic, small degree inflammation that impact on the health of cardiovascular system, brain, and kidney, heart, and so on tissues with the predisposition to develop a failure of all these organs and apparatus. And so we have to try to understand what is the final effect of sarcopenia. So I'm showing you here the results of a recent meta-analysis where the researchers have investigated some interesting parameters related to the mortality of the subjects affected by sarcopenia. And as you can see here, the presence on the diagnosis of sarcopenia in the patients increase very much their risk to die for any kind of mortality cause. And if we consider overall, independently from the length of the follow-up, we have an odds ratio of 1.660. That's like to say that sarcopenic subjects have the 60% around of risk to die for any cause of mortality compared with subjects without sarcopenia. And this seems to be relatively unrelated by the diagnostic methods that we use to define the diagnosis of sarcopenia. On the contrary, we can also see that the simple anthropometric measure of decrease of muscular mass is probably the stronger predictor of mortality in a sarcopenic subject, followed by DEXA and BIA. And if we consider the association of sarcopenia prevalence in different disease group in papers that have enrolled also control subjects, we can see that there is a strong, even if variable, association of sarcopenia with the prevalence of dementia, of type 2 diabetes, of chronic obstructive respiratory disease, and the same is also evident when we consider the articles that are describing the disease group without any kind of control. And the same is also stressed in this different charts that again show how sarcopenia prevalence is very prevalent in this chronic disease. So then there is always the problem. There will remain the problem around this lecture to distinguish how the sarcopenia is one cause of dementia, type 2 diabetes, and worsening of respiratory disease, and where the dementia, the type 2 diabetes, and the respiratory disease increase the risk to develop sarcopenia because reduced motility and change in dietary habits. Anyway, and the same is valid also for cardiovascular disease, as you see here on the right. But the main problem is that the two conditions are often co-present in the same subject, and one seems to worsen the second one, and the contrary is also true. The conclusion is that anyway, when we have a subject recovered in a hospital who is affected by sarcopenia, both muscle strength and sarcopenia are better predictors of increasing cost for the management of the patients, even compared to age. So this is something that we have to always remember. We just cited the possibility that the sarcopenia could be related to chronic degenerative disease as a consequence of this disease. However, we have also to say that the common risk factors could both increase the risk of sarcopenia and some chronic disease, and sarcopenia should become a further risk factor for these diseases. In this nice chart, you can see something about what we are trying to say, and that is really interesting because it's applied to something that is really actual, like the problem of the COVID-29. In fact, the COVID-29 containment measures causing social distancing, quarantine, isolation, travel restrictions on is forcing subjects to reduce their movement, their physical movement, to change their lifestyle habits, including food intake, with appetite dysregulation and so on, with a lower exposition to the light, so also with a decrease in vitamin D synthesis and so on, with the stress, with the chronic stress that cause increase in oxidative stress and in plasma cholesterol level, in pro-inflammatory cytokines and so on. And all of this reduce the muscle protein synthesis, in increasing the muscle protein breakdown. The final consequence is the loss of muscle mass and function, the increase in adipose tissue accumulation, and one more time, all these factors are related with increase in cardiovascular disease risk and type 2 diabetes risk, and the risk of osteoporosis and fractures, and cognitive decline, and depression, and physical frailty, and impairment of quality of life. What we know is that there are some factors, for instance, like sleep duration and quality, that now we know to be very related to cardiovascular risk, and that are strongly impaired by restriction situation and by stress and so on, but that they are also related to change in body weight. So the sleep restriction, reduction, impairment also change the ability of the body to consume fat, and the people that is sleeping less hour is more keen to accumulate fat, with all the consequence that you can imagine in terms of cardiovascular disease risk. And this is the final risk effect of these conditions are particularly evident in elderly subjects that are more frail, and from a cardiometabolic point of view, it is particularly evident as regards some specific conditions, like for instance heart failure. Heart failure is one very a largely prevalent condition in general population, in particular in elderly people, that is strongly related to sarcopenia. In fact, all conditions that are strongly related with sarcopenia, like systemic inflammation, like oxidative stress, like physical inactivity, in this case as a consequence of sarcopenia, and mitochondrial dysfunction related to, one more time, the physical inactivity and the decrease of the number of muscle cells, and so of cells that are usually very rich in mitochondria. All of these are risk factors also for the development or for the worsening of heart failure. Another condition that is strongly related to sarcopenia, and this relation is often not so strictly monitored, is the association between a very severe atherosclerosis related disease like peripheral obstructive arterial disease, in particular when related to the lower limbs, and sarcopenia. Here we can see the results of a very interesting and recent meta-analysis of clinical trials investigating the relationship between low skeletal muscle mass and peripheral arterial disease of the lower limbs in subjects, in patients undergoing revascularization. And what we can see here is that there is a trend toward all worse outcomes in patients that have both peripheral arterial arterial disease and low skeletal muscle mass. As you can see here, these subjects tend to have higher per-interventional mortality, lower survival. They have a very longer hospital length stay. They have a lower limb salvage, and they have a higher risk of amputation during their lifetime. So these comorbidities are very risky as regards the cardiovascular health of the subjects. Another concept that we have to remember is that sarcopenia is also strongly related to type 2 diabetes, in particular because of increase in insulin resistance. As we can see here, a very easy index of insulin resistance, like triglyceride glucose, is dramatically related to low skeletal muscle mass index. So that's like to say that the higher the insulin resistance, the lower the skeletal mass index. That's like to say a very higher risk of sarcopenia. So there is one more time a double side of the problem, because the lower the skeletal mass, the higher the insulin resistance, the higher risk of type 2 diabetes. From one side. On the other side, the type 2 diabetes often cause worsen the prevalence of the existence of sarcopenia. Both because inflammation, systemic inflammation, oxidative stress, but also because of often a change in dietary habits related to a decrease on overall in the number of calories, when probably the diabetic patients should be treated with a more rich diet in proteins than in other dietary components. And in the same concept, when we see the correlation between peripheral artery disease and muscle wasting in heart failure patients, we can see that there is a really strong linear correlation. So what we can do to care and to prevent the sarcopenia, we have just to say something like this, but we have to repeat it both in normal aging subjects and in ill subjects like one affected by heart failure. Of course, we should improve our ability to prescribe exercise training. We have to suggest specific dietary intervention, in particular slightly increasing the content of proteins in the everyday diet. There are some pharmaceutical agents that are under evaluation, in particular some hormonal substances that could have some impact in specific cases, but they have to be prescribed by really specialists in the management of these drugs. And there are also some dietary supplements or nutraceuticals that could help our patients. As we said before, if we want to reverse the problem and to improve the prognosis of our patients, we have to try to reduce the inflammation of our patients and to improve or recover the amount of muscle that it could be rebuilt even in late phases of the disease. And how to do it? From one time, the first care should be the increase in physical activity. So now here we have a schema that is very, very interesting, very well done, but is very, very good to manage people that is already trained. Now we have to think that the most part of patients that we see with the diagnosis of sarcopenia, they are nearly totally inactive. So we have to consider this protocol as our aim. That's like to say that we can even move more slowly when beginning with the prescription of the physical activity, with the aim to arrive to 3 sessions per week, with 2-3 sets per exercise, with 7 to 10 repetitions per set, and with mild to moderate training intensity, and also respecting some minutes between the series of exercise. So when we be able to do this, we can obtain a very good results in terms both to prevention, but even to slowing the sarcopenia we have diagnosed. But we can also help our patients while introducing some dietary supplements in their diet if we are not able to increase the overall intake of proteins, for instance, because of relevant kidney failure, or because the subject doesn't eat animal food, so like for instance vegetarians or even worse vegans, we can add their diet with single amino acids, like for instance leucine, eventually associated with vitamin D, and as we see in this double-blind randomized clinical trial, it could induce an improving effect in the fractional synthesis rate of proteins even after a short-term supplementation. And this is something that it can be do very easily with just one administration at breakfast, and you can see here the results. That is really, really interesting. And with the same approach, just in 6 weeks of treatment, we can also see an increase in appendicular and leg lean mass in the same subject, and you see that the effect is really, really impressive compared to the control group. So this is one of the options that we have seen in the literature in the recent times. Another nutraceutical that seems to be very relevant for the preservation of the strength, and in some subjects even in improving the muscle mass and the muscle strength, is the supplementation of omega-3 polyunsaturated fatty acids in a relatively large amount. You can see here there are more than 3 grams of eicosapentaenoic acid and docosahexaenoic acid that are nearly equivalent to 200 to 400 grams of freshwater fatty fish, compared to placebo over 6 months. And we can see one more time some interesting results in terms of thigh muscle volume, hand grip strength, and RM strength. So In conclusion, we can say that sarcopenia is highly prevalent in elderly population. That is associated to low self-perceived quality of life, high social cost, chronic degenerative diseases, and mortality, with a specific focus with cardiometabolic disease. There is a bilateral connection between sarcopenia and cardiovascular disease, where one seems to negatively influence the other one, and so it is very important to consider both factors when evaluating the patients. And the milestones of treatments are the prevention, first of all, the physical activity, a structured, prescribed physical activity, personalized, tailored to the single subject's ability and training. Dietary proteins that could be improved both in terms of quality and quantity without going towards an excessive charge of proteins, and when this is not possible, with some supplements, for instance, with essential amino acids that have no contraindication even in chronic renal failure patients, vitamin D, that is very relevant for nearly the most part of the adult population, and omega-3 polyunsaturated fatty acids. I thank you very much for your attention, and good afternoon.